Kia ora tato. So welcome everybody to our program today. It's a pretty busy one. We're going to concentrate on the globe and the orbit. And we have a couple of people coming up first who have looked at the questions for today. So first, Chris, is Chris with us at the moment? Chris, oh, there you are, Chris. Sorry, I was just blind to your name at the moment. Chris, would you like to share screen and give us your 5 minutes and 5 slides?
Yeah, sure. So let me just find it.
I'm going to be a timekeeper.
Oh dear.
And I'm going to give you the beep at like 30 seconds to go.
You guys see that?
Yep.
Yeah, looks great.
Okay. And yeah, feel free to tell other people to do things differently if you want something different, but all good, we'll get going. So my topic is melanoma and retinoblastoma, so 2 small topics. And so looking at the common sort of topics that they look at, we'll start with melanoma first. So of that list, look, they've pretty much asked most of them in the past, which is, kind of understandable. It's a fairly important topic. But so, they ask about, the pathogenesis and clinical micro and macroscopic features. They ask a lot about prognostic factors. They ask a lot about distinguishing from nevi and the different kind of features that would help you to do that. Less so specimen preparation and the lab procedures. Comes up a fair bit in the examining slides at the end. There was one question on interpreting lab reports, but that was really just sort of code for prognostic factors. So I'll sort of put that in orange. And then a fair bit on sort of radiotherapy and the sort of pathological changes post-treatment from that. And the complications. So really, it's a good one to know in a fair bit of detail. Retinoblastoma was a little bit more selective. So there was a lot on genetics and the sort of the 2-hit hypothesis, Knudsen, retinoblastoma gene, that sort of thing. And there was a fair bit on the differentials of leukocoria. So you want to know that presentation well, your differentials and the different things that might be associated with each of them. And again, it comes up every now and then in the histological sections as well. So things that were a little bit tricky in terms of the questions that I went through. So for melanoma, so 55-year-old Caucasian female presents with pigmentation in the left caruncle area, noted for 6 months, fine. Describe the pathological possibilities with reference to pathogenesis and histological features. So I thought that was a little bit of an odd way of asking things, but I suppose it comes down to, what are your differentials and what are the pathological features of those differentials? The second question there, so iris melanoma, so difficult management problems, why is this the case? And so again, a little bit of a left field question, but I suppose again comes down to the prognostic factors of iris melanomas and their easy spreading and that sort of thing, in addition to your normal melanoma subtypes and that they present late and all that sort of thing. So they were the main kind of slightly different ones from melanoma. The rest of them were relatively straightforward. And retinoblastoma, again, most of them were fairly straightforward. This was the only one that I found that was slightly different. Why would this child have presented to an ophthalmologist? Again, just code for signs and symptoms. But the only thing sort of different to that list that we showed before. In terms of common tasks, there wasn't really much to say here. It was all fairly straightforward as well. So the model question that I chose was discuss the pathogenesis and histological features of choroidal melanoma, relate these to how choroidal melanomas present symptomatically. So I thought this was fairly typical. They'll usually ask something about the pathogenesis and then maybe one other thing, so either the genetics or the treatment or the symptoms or that sort of thing. So the model answer I thought was a bit of an info dump, and there was no chance that I was going to get down that much in 12 minutes. Things that would have been better for my response. So usually I'm someone who writes sort of full sentences, but I think dot points here really works better. And I suppose just the specifics of the classifications, the mortality rates, the genetics. I found that there were a lot of different, especially with the prognostic features. There are a lot of different places that had, like 15-year mortality versus 5-year mortality versus, survival rates versus risk of transformation versus so lots of statistics. And so I thought maybe, if you picked the COM study and looked at that as sort of the epidemiological side of things, and then knew the calendar classification, that would be a good starting point. And then if you wanted to go further, you can. And I forgot to put in stains and that sort of thing, which I think just comes down to practicing the structure and making sure that you sort of have a routine that you go through when you're answering these sort of questions.
30-second wind up.
Easy. So in terms of tips for melanoma, know the prognostic factors. They seem to come up the most commonly, and the classifications. Be clear on the different types of pigmented lesions, so a nevis versus a melanocytoma versus a melanoma, and the differences between them, and the melanoma on different parts of the body. Then you can use it as a base for a lot of different questions, and they seem to pop up as well. But they won't really ask you about everything because it's such a big topic. And then retinoblastoma, basically know the genetics and know the differentials for leukocoria, and that will stand you in pretty good stead for most of the things that I've seen there. All
Thanks,
good?
Chris. I really liked your summary. It was excellent. I really like the way that you highlighted the key words, because you're right, it's a big topic, and just honing down on what they want using dot points and actually answering the question is exactly the thing to do. Otherwise you'll get lost and just run out of time and lose points. The other tip about melanoma
absolutely.
that I would put in is genetics. I included that under prognostic things, but more and more they're going to be asking you about genetics in the written questions. Recognizing the difference between the genetics for uveal and conjunctival/skin melanomas is really important. And there's a new immunohistochemical stain that I will be talking about that relates to the genetics and the prognosis. If we just go back one slide.
Oh, sorry. Start sharing again. Yes.
Yeah, so I agree with your last sentence. Practice structure. Structure is really important, and we're going to be practicing structure, particularly on the 24th of October in the last part of the day. We're going to concentrate on practicing structure in your written answers, because that's really important. Yeah, and dot points is great. We love marking dot points. If you could go back 2 slides to number 3. It's interesting that you've chosen curly questions that are actually clinically based, because you would see the causes of pigmentation in the left carbuncle area more than me. And I think that the thing to not forget is all the benign things that cause pigmentation in the carbuncle. Just standard racial-based pigmentation, or think of all the patients that you've seen with pigmentation in the carbuncle, and then work through the levels of pigmentation. Just the epithelium is pigmented without any proliferation of cells, or there's benign proliferation at the junction, or there's benign proliferation at the junction and into the underlying stroma, or it's atypical, or it's a melanoma. So yeah, great. Okay, so iris melanomas. So one of the things with iris melanomas is something that Amanda and I struggle with often, and that's telling the difference between the melanoma and a nevis, because they are incredibly bland. So, hi Jenny, how are you? So, so it's Zia, sorry, is it?
Yeah.
Yeah. Iris melanomas are a little bit different from other uveal melanomas, and it's worth learning a couple of points about them that distinguish them from your standard choroidal melanoma, like the blandness. Okay, but that was really, really well done, Chris. Thank you. You got any comments, Amanda?
Good. I like this way of extracting the really the meta-analysis of the questions rather than just recycling what you can read in the textbook anyway. So that's our approach for this exam preparation.
Okay, so next is John.
He's not here yet.
John's not here.
No,
Okay.
I'll message him, see where he's up to.
All right. If John's not here, then I'll do my talk and he can go afterwards. Okay. So I'm going to have a little chat to you all about uveal melanomas now. I will share my screen.
I will monitor the chat box. Remember, if you've got a question, put a question mark first. If you've got a comment, just comment.
Yep.
Yeah.
Okay. So in presenter mode here. All right, ocular melanocytic tumors. So it's important to develop a language around describing the gross and low power appearances. And it's very much about, she says, losing her thing. It's very much about just describing it the way you would describe any surgical mass, and you're good at describing surgical masses. So you know when you're describing a surgical mass, you want to describe its position, its size, its shape, its color, and the structures upon which it impinges. And it's exactly the same with uveal melanoma. So don't be put off by the fact that it's something special, you know, mushroom shaped, dome shaped, large mass occupying most of the vitreous with extensive retinal detachment. Impinging on the ciliary body, that's an important prognostic factor. Extending through the sclera. So use your general skills when describing the low power appearances of a melanoma. Don't forget to specifically, even at low power, describe the prognostic features. So this one here, for example, is clearly extending through the sclera surrounding a vessel. This one here looks like it's in the vessel, and you can see that at relatively low power. Orbital extension, a large amount of pigmentation. So if you're asked to describe the macroscopic features, don't forget to describe the stuff on the outside of the eye, as well as on the inside of the eye, as well as what you can see through the ophthalmoscope. So 3 things: ophthalmoscope, cut section, and what you can see on the outside of the eye when you're describing the macroscopic and prognostic features that you can see macroscopically. What's really important is recognizing this mushroom shape, because it means it's through Bruch's membrane, which again is an important prognostic feature. It's sometimes hard to see whether it's through the retina, but often at low power you can see. You can see other things at low power, like the subretinal exudate. So big message is don't move on too soon in either your written answer or your description in a histological slide from low power. You can get such a lot. let's think about the calendar classification. In the latest variation of the classification of melanomas, these spindle A cells are now thought to be nevis cells. And really, we begin our classification with spindle cells. They're kind of clumped together as spindle cells. So remember that spindle cells can become cut crosswise and appear as round shaped. And they're quite often like blunty oval ones. So I often describe them in terms of vegetables. And these ones are kind of the fat orange kumara shape. Now they're quite different to epithelioid cells, which look like great big fat fried eggs. Here we go. And this bit shows them quite nicely together. So even if one of these spindle cells was cut crossways, it would not resemble this great big fried egg. So the fried egg's got this big cherry red spot in it. That's the nucleolus, right? And then there's the yolk, and then there's the extensive white, and it's just bigger than the usual spindle cell. Okay, so quick quiz. What cells are these?
Type in the chat box. Go. All right. Others? Yep. Spindle B.
Yeah, so some of them are spindle B. Here we go. Some of them have got nuclear grooves. Okay, so these would have been called spindle A, but probably they're just part of the melanoma. So yes, spindle B. And this one.
Can you see the chat, Diane?
I can't see the chat.
Okay. So spindle B.
Yeah, this is a really, really obvious spindle B, right? Notice we've got little nucleoli appearing, but they're not the bright cherry red nucleoli of epithelioid cells. Which these?
Type that in. Go.
Go.
Yeah.
Clearly epithelioid. Now this photo has been taken with quite a blue cast, and these cherry red nucleoli are actually purple.
Blueberries.
They're blueberries. That's right. They're not cherries. They're blueberries. Well done. Yeah. Okay. And this one?
Mixed.
Great. Okay. So in the new classification, where do we do the cutoff? I'll come to that in a moment. More specifically when we're talking about the College of American Pathologists reporting schedule. But it's easy. It's at 90%. Okay. So if it's 90% spindle, it's pure. If it's 90% epithelioid, it's pure. If it's in between, it's mixed. Okay. So we know that cell type is really, really important in terms of prognosis. And probably that reflects the genetics as well, because I found that the epithelioid cells mostly come back with monosomy 3. So let's have a think about how we measure histologically. We still measure the things that you measure clinically, okay? So you can kind of cross-fertilize that information. We measure the tumor diameter at the base, and as you know, it's clearly related to the survival. In addition, smaller melanomas are likely to be spindle cell tumors, possibly because they just grow slower. And so are likely to present at a much earlier stage. Okay, and so tumor size and extension when you're talking about prognosis is really important. So there's a link here to the College of American Pathologists protocol, which I will nip into. So this is what we always use to report it, is protocols put out by the College of American Pathologists. And if you type in ocular melanoma here, I think it's
uveal melanoma.
Uveal melanoma.
Yeah.
Okay, it will bring up the protocol for examination of patients. So expect when you get your pathology report back from the pathologist, he or she will be using this protocol. And what we do is we choose phrases that fit into these categories. So we will tell you exactly where it is, because we're going through and tick boxing or deleting the correct statements for this. It gives you an idea of the specificity that you should be talking about. So, for example, tumor location, we want to know where its anterior and posterior margins are, and you could incorporate that when you are describing where the tumor is. Down here is the lovely staging system. Now, if we scroll down, these are notes for the pathologists on how to cut up a melanoma. But I hope that you're familiar with this, this T&M staging system, where we decide which category the tumor is in depending on the size, which is the basal diameter and the thickness. Okay, so that's really important to know about that. Both dimensions fit into the staging.
So Diane, there's a good question here from Jess.
Yeah.
Is there a measuring tool on the slide in the exam? What viewer are they using? Do we know?
I don't know what view they're using. I would, if I was you, know that a globe is about 25 millimeters in diameter. And so you can say approximately by estimating the proportion of globe diameters that you can use. But I don't know whether they're provided with a measuring tool. Okay, so I've listed here the most important histologic factors. What people often get confused about is the extravascular matrix patterns. And also, many of you haven't heard about this new immunohistochemical stain called BAP1. Okay, so hopefully, my next slide, I'll just talk about this. So when people talk about extracellular matrix patterns, what they're talking about is the blood vessel pattern. Okay, so here you can see numerous small blood vessels. Sometimes they're so numerous they look like little renal glomeruli. Okay, so if you want to talk about that as a prognostic factor, then understand that what they're talking about is high vascular density, whether or not the tumor has a high vascular density. Right. If you're looking down the microscope or the virtual microscope at a melanoma, right, here are some tricks and tips. So often around the scleral nerves and veins, you'll see pigment, and that's just pigment. You've actually got to see the melanoma cells with their big nuclei around the nerve. Don't be fooled by pigment. Always remember to look in the trabecular meshwork and around the ciliary body. Remember that melanomas cause iris neovascularization. And remember to look not just at the optic nerve, but also in the meninges, because sometimes melanomas go directly into the meninges, particularly if they're sitting parallel to the optic nerve. Okay. So genetic abnormalities. So I'm sure you all know this, that monosomy 3 is bad, gain of 6q is a good prognostic feature, and there are 2 mutually exclusive pathways. Okay, so melanomas can either go down the monosomy 3 or the chromosome 6. And if they're down the monosomy 3, then they can have gain of 8q, which is even worse. So there's kind of 3 genetic categories that they fall into. What the technology that we use to do the chromosome counting is FISH. So FISH stands for fluorescent in situ hybridization. And some people find FISH a bit mysterious, but what we do is we use fluorescent markers and a microscope that has a fluorescent light source. we label the chromosomes near the centromere, okay, with these different colored dots, and then we count the dots. So if we label this tumor here for chromosome number 3, okay, then we will be able to just see one of that colored dot in a cell. If we label chromosome 8 at the same time red, then we'll be able to see 3 copies of chromosome 8. So this one here, most cells have just got one green dot for a 3, and they've got 3 copies of chromosome 8. It's a bit fuzzy because the cells often overlap, and there's a real art to interpreting it. Okay. So this is a melanoma cell, and you've probably heard of the Gneck mutation, okay? Like the BRAF mutation, that happens really, really early in the evolution of melanoma. It occurs before it becomes a nevis. It essentially tells the tumor cells they don't have to stay apart anymore. So just about all the tumor cells will be Gneck mutated, just like just about all the skin melanomas are going to be BRAF mutated. So the Gneck is part of the founder mutation and isn't really part of the prognostic thing. I think about a quarter of melanomas will arise from a previous nevis, but there's a very, very low rate per year conversion. So once it does convert, it goes down these 2 pathways where it gains 6P and becomes this class 1 melanoma. Sometimes it gains an 8Q, and these are the uncommon types of melanomas. Unfortunately, the worst kinds of melanomas are the most common, where they lose chromosome 3 and then either gain or lose 8. This immunohistochemistry BAP1, it actually stands for BRCA-associated protein, and it now means that we can tell whether or not this tumor is going to behave aggressively by doing an immunohistochemical stain. So BAP1 is located on chromosome 3 and will be mutated, i.e. will stain brown, in tumors that have a chromosome 3 mutation. So you will see that coming through in your reports as standard now, and this is what it means. It means it's likely to be a chromosome 3 mutation tumor. BAP1 is actually, again, I think an independent prognostic feature. Okay, so we now have molecular uveal melanoma subsets, class 1 and class 2, depending on whether they are chromosome 6 or chromosome 3 loss. And then we can, in the chromosome 6 ones, we can classify those up to intermediate if there's also a gain of 8Q. There we go, and there's some key mutations. As I said, BAP1 is associated with a chromosome 3 loss. Okay, any questions about genetics of melanomas? I'm sure you've heard that talk before.
Diane, I noticed you said you were talking about the immunohistochemistry and BAP, and then you said loss of brown staining. What does that mean? I thought all melanomas were brown.
Yeah. So that's a good thing. Yeah. So there's the melanin that is brown, but in immunohistochemistry, one of the markers that we use stains the nuclei of cells brown if the BAP is mutated. So if the BAP is mutated, the nucleus goes brown. It's not just the cytoplasm.
I think we'll show you some pictures later. Yeah.
I think we will.
Yeah.
Yeah.
Can I ask a quick question?
Go for it.
With your diagram of the genetics with the where it peels off, yeah. Did you say that the gain 6p and the chromosome, the 8q were mutually exclusive, or did I?
6p and the chromosome 3 that are mutually exclusive.
Right. Okay. So 6 and the 8q is also mutually exclusive from.
No, it can happen to both of them.
Okay.
Yeah.
Yeah.
And another good question here from Johnny, and Johnny's not the only one, because I was asked this the other day. Oncology registrar rang me up and said, my patient has a uveal melanoma and some things in the liver. Can you do a BRAF mutation for me, please? What would be the answer, Diane?
So my answer would be to the oncology registrar is that BRAF is not usually useful in melanoma from the uvea, and perhaps I might advise you on some different genetics that might be useful. The reason they're asking for it is that there is a drug that can treat melanomas that are BRAF mutated. Now, if they go, yeah, I know all that. I know that only 2% of uveal melanomas will be BRAF mutated. I want to do it anyway. I would say, okay, it's your funding. If you want to do that, that's fine.
Yes, I sent a paper about the very low incidence of BRAF mutation in uveal melanoma, because we know the pathogenesis is different from cutaneous melanoma.
Yeah.
What about iris melanomas?
Iris melanomas, the BRAF mutations are slightly more common. Yeah.
What about conjunctival melanoma?
They're just like skin melanomas.
So yeah, the answer is it depends where it is in the eye.
Yeah. Okay.
Cool.
All right. So sometimes questions ask you about masses in the iris. Please don't forget that there are other things that cause lumps. I don't need to tell you this, right? There are other things that cause lumps apart from melanomas. I think there was one question that asked about like masses in the iris, and people forgot to talk about cysts, and people forgot to talk about leiomyomas. They just talked about pigment lesions. So iris melanoma versus iris nevis can be a real problem, Often, what we need is some really good clinical information to help us decide, okay? If you could send us pictures, that would be great. We're particularly interested in the lifespan of the lesion and its natural history. We're interested in the presence or absence of feeder vessels or inflammation. All of those can help us make a recommendation of what this is. And I say make a recommendation because sometimes we can't tell in iris melanomas because they are so bland. And you will have seen pictures like this in textbooks, and I couldn't possibly comment on the clinical features not being an ophthalmologist. But what I can say is sometimes all we can say is this is an atypical melanocytic proliferation. They can be really bland and sometimes we can't tell. Here are some features that we might be able to help. So this is an iris nevis. It's really just a little lump. It's very well regulated. This is an electron microscopic view. When we look down the microscope, it's like confined to the surface. It's not invading down. It's not forming great big lumps. So that's a typical nevis. When we get to a melanoma, we can see, particularly in this one, the cells, man, they're all over the place. They are really lumpy. These are probably a few epithelioid fried eggs happening through here, and it invades down. We can see epithelioid cells. When we have those, it's easy because you don't get epithelioid cell nevi. And this is probably what used to be the front of the iris, and it's forming this great big mass across the top here. This is slightly more tricky because it's a spindle cell lesion, but again, it's expanding the iris, and here we've got the front, and it's forming quite a big irregular lump on the top. So this is also looking like a melanoma. So often the cells are bland, and we have to rely on the growth pattern that helps to tell us whether it is a melanoma, and of course, the genetics. It can be really hard to get enough material from a tiny iris biopsy. So we preserve it, just cut slices and send some off for genetics early, because we know, as well as being prognostically important, it can also be diagnostically important in iris melanomas. I'm sure you know the A, B, C, D, E, F guide. This is a clinical guide. I'm not going to talk to you about it. And if you want to know more about it, then I recommend this, okay? Yeah. This Nature Disease Primers, published in 2020, has a really, really nice summary of uveal melanoma, marrying both clinical and pathological things. It comes, of course, from our friends, the Shields, in Philadelphia.
It's a really good paper, that one, and it's got some nice diagrams and pictures. I'll put the link in the chat room.
Great. Okay, so I'm going to now... I
see Johnny's back. John's back.
Stop sharing screen. I'm just being a bit of a... getting out of here. Sorry, I'm having trouble with finding my Zoom thing. Too many things. Stop share. There it is. It's on there. Right. Okay. Right, Johnny. Okay. Well, John. Yeah. Okay. So you were going to give us your top tips on oncology and genetics.
So essentially, my topic was oncogenes, tumor suppressor genes, and how to read a genetics report. Very common topic. Almost seems to be one every 2 to 3 years. Oncogenes and tumor suppressors, and almost always they ask us, give us an example. And I think an example to know well, and one which recurs as well, is retinoblastoma, which I think Chris covered just now. But essentially, the questions are very similar, and I've sort of like given an example how to answer them. So essentially, oncogenes are normal genes, stimulate cell division. When there's a gain of function, it becomes an oncogene by mutation, and you get more expression of normal proteins or overexpression. And examples would be, for example, in uveal melanoma, c-Myc, and in cutaneous melanoma, as we were discussing just now, it's BRAF rather than, which is more exclusive to cutaneous rather than uveal. I'll just leave this here so people, I'm sure, can read this later. And in terms of tumor suppressor genes, it's a normal gene. It's usually autosomal recessive in manner because you need loss of both forms to have cancer. And common, so in tumor suppressors as compared to oncogenes, there's a loss of function before you get cancer formation. And examples would be retinoblastoma, pulling down, NF1 and P53. In terms of the genetics questions, there's actually, I couldn't really find much online from the previous past papers because I didn't publish the papers. But from what I could see, there was a few questions on cytogenic nomenclature. I think there was a question on in Down syndrome and how it's mutated. It's quite, I think the people who said the question weren't quite sure of how to answer this one, but I found this table which might help with it. So I think things like mosaicism and that might be important.
Johnny, your sound's really bad. Would you be able to?
A microphone is always had problems. Sorry.
Okay.
Yeah. Essentially, I was trying to say that there's not many genetics questions that I could find online just based on because they're all MCQs. But I think there was a question recently that people had trouble with, which was the standard genetic nomenclature. And I thought this table might help people later on in their studies. It's just about, the example question was in Down syndrome, how would you annotate the chromosome? So usually you can write 47XY plus 21. But there's other methods of, there's karyotypes that might manifest as Down syndrome as well, which I think mosaicism is one of them. And I think some translocations as well. I thought this table might be helpful for later. And that's about it for that topic, I think. Any questions or?
Yeah, would you, so what are your top tips for people learning this topic, John?
Top tips would just be to know the definition well for oncogene and tumor suppressors, because it's a very common topic. In terms of the examples, I think just know 2 or 3 at the back of your head quite well, because they'll ask those as well. It seems to be always section A questions, so usually quite short. So you probably don't need to go into much detail for it. And I guess the main pitfalls would be when they ask about oncogenes, you probably focus more on the oncogene rather than the proto-oncogenes themselves.
Good, so learn the definitions well and know some examples really well are your top tips. I think those are good top tips. Okay, thank you. Any other questions? Do you want to stop sharing?
No other questions in the chat room.
Okay, so I think we might be up to a
break.
5-minute break.
Stop recording.
Thank you for that thing. I will stop recording.
5 minutes.